All right, so a very good evening to all of you. Yes, Himanshu, hi, and Shivank, hello. So, good evening to all of you. So, I welcome you all to the last minute revision program, session 4 or the part 4. And I myself, Dr. Rajesh Gubba, I am the general medicine educator on this Unacademy platform. Now, as so today morning also we were discussing last minute revision program part 3, but there was little disturbance in the end, so I will do some of the multiple choice questions which I have to discuss in the last minute revision part 3 for 5 minutes, and then we will move on to this particular session. Okay, so let me start the discussion now. This is one of the very important question that is very frequently asked in your the postgraduate entrance exams and as well as the Fmge exams as well. So thumb sign on the CT scan is seen in Cardoma, metastasis, glioblastoma multiforme, astrocytoma. So can anyone answer this question? Right, so very good, Santanam. So the answer is the thumb sign on the CT scan, it is present in clinical condition called as Cardoma. Right, so first of all, you should know what exactly you mean by this word Cardoma. Cardomas, like they are the one, these are the tumors which originate from the base of the skull, right, and they go almost up to the tailbone. From the area of the base of the skull to the tailbone, anywhere this particular tumor can be present. But remember, if you take the frequency of these particular tumors, these are one of the rare tumors, right? These are one of the rare tumors. And I'll just show you the image of this particular Cardoma. Right. So this is what is your thumb sign. So you can see here. Okay, so if you want me to draw, this is your exact thumb. Okay, so this is your thumb sign. So thumb sign, it is characteristically seen in patients with the Cardoma. Cardoma is one of the rare tumor. Where is the origin of this? All the way anywhere from the base of the skull up to the tip of the spine. So this is what is your thumb sign seen on CT scan in patients with the Cardoma. Now, yes, answer this question. Fever blisters can occur due to HHV6, varicella, primary HSV1 infection, reactivation of HSV1. Fever blisters can occur due to HHV6 stands for human herpes virus 6, varicella, primary HSV1, reactivation of HSV1. Right. So yes. So Ritesh Raja has answered this correctly. So it mainly occurs due to reactivation of HSV1. It is not the one which will occur due to primary infection of the HSV1. So this is one of the very important point that you should remember. Most of you will tend to go with the answer of primary HSV1 infection, but that is not the correct point. The fever blisters, they mainly occur due to reactivation of HSV1. Now, followed by that, you take your HSV2. Now, yeah, so HSV1 is the one which is associated with the orofacial infections. But the blisters, they will occur at the angle of mouth only whenever there is reactivation of your HSV1. Now, I'll ask you one important point about your HSV2. So, can anyone answer where will be the site of infection associated with HSV2? Any one of you? HSV2 is the one, right, very good, Santana. So HSV2 is the one which is associated with the genital infections. And remember, if there is presence of umbilicated vesicles, mainly think of your herpes simplex virus infection. So initially it will cause the active infection, and later on the HSV virus, it will go and get established in the nerve. So in the nerve it will be in the form of the latent infection, right? Yes, Likit Gaud has answered this very correctly. So above the umbilicus, right, above the umbilicus it is your HSV1, and below the umbilicus that is your HSV2. So this point you should remember, right? Above the waist and below the waist. Okay, right. And after the active infection, the HSV virus will go into the nerve, and in the nerve it will be present as the latent infection. And the secondary phase, it is characterized by the recurrent disease. So whenever there is a recurrent disease, that is the point when you will have the presence of these particular fever blisters in patients who are affected with the HSV1. So to summarize, the fever blisters can occur due to reactivation of herpes simplex virus 1. It is not due to primary HSV1 infection. So this is a very important point everyone should remember. Next, we will move on to the other question. Yes. Now, whenever there is a recurrence of your HSV infection, what are all the disorders the individual can develop? The individual can develop herpes labialis, herpes genitalis, Kaposis varicella, herpetic whitlow. Can anyone tell me what do you mean by this whitlow? Any one of you? What do you mean by this herpetic whitlow? Right, very good. Santanam, excellent. So it is, yeah, so it is the one infection in the fingers. That is nothing but your herpetic whitlow. And the other things are that they can have the keratoconjunctivitis. So these are all the infections that can be seen with the recurrence of HSV infection, herpes simplex virus infection. All right. Then, so that is about your what will happen whenever there is reactivation of HSV. Yes, you take this clinical question. A patient with tubercular meningitis, he was taking anti-tubercular therapy regularly, and at the end of 1 month of regular intake of the drugs, there is deterioration in the sensorium that is being noted in the patient. Which of the following investigation is not required on emergency evaluation? MRI, CT scan, CSF examination, liver function test. Very good, right? Excellent, Santanam. So CSF examination is the one which is not required on emergency evaluation. Okay. Yes, Santanam, I'll ask you one question. Like all of you, whoever are answering the CSF examination, tell me, why do you want to do liver function test on an emergency basis? Why do you want to do liver function test on an emergency basis? Right. So the purpose is that the individual is on the anti-tubercular therapy. So when the individual is on anti-tubercular therapy, majority of your anti-tubercular drugs, they are hepatotoxic. Right? Majority of your anti-tubercular drugs are hepatotoxic. So this particular drugs might have caused hepatitis, and the individual might have landed in hepatic encephalopathy. Right, the individual might have landed up in hepatic encephalopathy, and because of this hepatic encephalopathy, he might have been in the altered sensorium, and that is the purpose why we do the liver function test. Next, now answer this question: why do you want to do CT scan in this patient on an emergency basis? Why do you want to do CT scan? Yes. Na easy method nai. Like what are you expecting? What are you expecting in the CT scan? Right, let me explain you. See, in tubercular meningitis, the complications what you can have. The complications what you can expect in patients with the tubercular meningitis is the development of hydrocephalus. Right, and this particular hydrocephalus, it is due to accumulation of your basal exudate. So if you want to rule out this particular hydrocephalus, and hydrocephalus is the one which makes the individual in altered sensorium. So in order to rule out this hydrocephalus, you can do this particular CT scan. That will give you the picture. Then coming to your MRI of the brain. Now what is the purpose of doing MRI of the brain? The other complication what you will come across in patients with the tubercular meningitis is tubercular endarteritis. right? Tubercular endarteritis. Now, what will be the manifestation because of your tubercular endarteritis? The manifestation of tubercular endarteritis, it can be infarct. A small infarct can appear, and the small infarcts can be seen by your MRI, and the small infarcts can make the individual to land up in altered sensorium, and that is the reason why you also have to do MRI. So you are doing MRI, CT scan in order to see if the individual has developed any complications. You are doing liver function test in order to see that is this anti-tubercular drugs might have caused hepatitis causing hepatic encephalopathy. That is the purpose why you have to do liver function test. And in an emergency basis, doing CSF examination is not very important in this clinical scenario, right? So that is what I want to convey you. Right. I hope everyone has understood this question. If anyone has any doubt in this question, please post. I'll be very happy to answer you. All right. So we will move on to the next question. Eosinophilic meningitis is seen with all except coccidiomycosis, cryptococcal meningitis, leptomeningeal metastasis, helminthic infections. Okay, so Santanam has answered as leptomeningeal in metastasis. Any other answer apart from this? Right. So the answer to this particular question is not your leptomeningeal metastasis. Right. Very good, Avinash Mukherjee. So Avinash Mukherjee has answered this very correctly. So it is in your cryptococcal meningitis, you will not have eosinophilia. Right. In case of cryptococcal meningitis, you will not have eosinophilia. Whereas you take in organisms like parasitic infections, like you take helminthic infections, definitely there will be increase in your eosinophil count. Yes. Avinash Mukherjee, you have answered that cryptococcal meningitis is the answer, which is correct. Now tell me, in cryptococcal meningitis, which cells are increased? In cryptococcal meningitis, which type of cells are increased in your CSF? Any one of you, please? Not neutrophils. In case of the cryptococcal meningitis, sorry, one second. Yeah, it is your lymphocytes which will be increased. Right, it is the lymphocytes which will be increased in patients with the cryptococcal meningitis. It is not your neutrophils. And what is the best test for diagnosis of your cryptococcus in the CSF examination? You have to do what is called the India Ink preparation and as well as the enzyme immunoassay. But between these two, the best one is the enzyme immunoassay for detecting the cryptococcus in the CSF. Okay, so that's a very, very important point. Now, see, this question is based on eosinophilic meningitis. When will you use the word eosinophilia in the CSF? When will you use the word eosinophilia in the CSF? This is also very, very important question. I'll tell you now. We use the word CSF eosinophilia when the number of eosinophil count is more than 10 eosinophils per cubic millimeter in the CSF. That is the point when we use the word CSF eosinophilia. Right? Next. The next point is, what are the most common causes of the CSF eosinophilia? Most common, as every one of you know, it is parasitic infections. And what are those parasitic infections? Mainly your nematodes like angiostrangulosis, gnathomatosis, toxocariasis, trichinosis, and cestode infection like cysticercosis, echinococcus, and tremodode infection like paragonimiasis and as well as schistosomiasis. So these are all your helminthic infections. The eosinophil count will be increased. And when will you use the word CSF eosinophilia? We use the word CSF eosinophilia when the number of eosinophils are more than 10 per cubic millimeter. Then, what are the other conditions where you can have increase in the eosinophil count? The other conditions are coccidiomycosis, leptomeningeal leukemia, ventriculoperitoneal shunt, lupus erythematosus, sarcoidosis, drug or contrast agent reaction, Hodgkin's lymphoma, and hypereosinophilic syndrome. So these are all the conditions where the CSF eosinophil count will be raised. But among all these, the very important what you should remember is the helminthic infections, right? And as well as your coccidiomycosis and as well as leptomeningeal metastasis. Right. So this is about your eosinophilic meningitis. The criteria to call it as CSF eosinophilia is a very, very important point. Yeah, this is another important question. Steroids are contraindicated in all except diabetes mellitus, tuberculosis, peptic ulcers, brain tumor. Are contraindicated in all except. Yes, any one of you? Tuberculosis. So yes, Santanam, you want to give the steroids in tuberculosis, that is what you are trying to tell me, okay? Any other? No. Yeah, Ritesh Raja has finally answered. Very good, Ritesh Raja. So the answer is the brain tumor. The answer is the brain tumor. Now let me explain you one by one. In case of diabetes mellitus, you should not give steroids. Right? You should not give steroids. The question is why? Why? Because steroids, they will increase the glucose levels. That is the reason why in diabetes mellitus, you should not give steroids. Next, in case of tuberculosis, now if you take tuberculosis, we have various forms of tuberculosis. We have pulmonary tuberculosis and as well as extrapulmonary tuberculosis. The point is that you take in case of tubercular meningitis, I definitely accept you should give steroids. But if it is in case of pulmonary tuberculosis, in pulmonary tuberculosis, the steroids are contraindicated. Steroids are contraindicated. But the point is, he did not give you there. He did not mention whether it is a pulmonary tuberculosis or tubercular meningitis. He did not mention. So that is the reason why I will not use steroids in tuberculosis. Right? That is the reason why I will not use steroids in tuberculosis. Next, in case of peptic ulcers, let me tell you one of the adverse effects of your steroids. Right? One of the adverse effects of your steroids is the peptic ulcers. Development of peptic ulcers, it is one of the adverse effects of your steroids. So that is the reason why in peptic ulcers, steroids should not be given. Now, the question is, yes, Ritesh Raja and Avinash and Rubin, you people have said like in brain tumor, you want to give steroids. So can you explain why you want to give steroids in brain tumor? Any one of you? Please tell me, why do you want to give steroids in brain tumor? Yes, Avinash, Ritesh, Rubin. Now, why I did not ask which tumor, right? Yeah, so Chasian. So you have answered it correctly and Santanam has answered right. Very good, Babji. So you have also answered. The purpose of giving steroids in the brain tumor is that surrounding the brain tumor, there is edema formation. Right? So to reduce this edema, we give steroids. To reduce this edema, we give steroids. Now, the question is how this edema occurs, right? Now, we have the cells called the glial cells. What these glial cells will do is, glial cells will increase the secretion of vascular endothelial growth factor. This vascular endothelial growth factor, what it will do is, this vascular endothelial growth factor, it will weaken the blood-brain barrier. Right, it will weaken the blood-brain barrier, and because of the weakening of your blood-brain barrier, there can be that will result in the formation of the edema. Now, when you give your steroids, what the steroids will do? The steroids will inhibit the production of your vascular endothelial growth factor, and thereby there is no edema formation. So, and what is that particular steroid that you need to give in patients with the brain tumor? That is your dexamethasone. So, dexamethasone is the one that you need to give in patients who are suffering with the cerebral edema, and that will reduce your vascular endothelial growth factor production. So, answer to this particular question, steroids are contraindicated in all except the answer is your brain tumor. In all other conditions, it is contraindicated. Now, we will move on to the next question. Yes. Treatment for neurocysticercosis in children. Albendazole 15 milligrams per kg per day for 1 week. Albendazole 15 milligram per kg per day for 2 weeks, 3 weeks, 6 weeks. How many weeks you give this albendazole? Okay, so Avinash want to give for 1 week. Any other answer? Yes, so Santanam has come with the point of 3 weeks. So the answer here is you need to give for 3 weeks. Right, it is not for 1 week. You need to give the albendazole for nearly around 3 weeks. The answer is 3 weeks. Right. Now, apart from albendazole, what is the other alternative drug? What is the other alternative drug for the treatment of your neurocysticercosis apart from albendazole? No, not ivermectin. Yes, praziquantel. The other alternative drug like what you have is the praziquantel. Okay. But what do we use more? Preferably we use albendazole, and there is also a reason for that. Why we use albendazole compared to that of praziquantel is that albendazole is the one which will destroy the subarachnoid and as well as the ventricular cysts also. Your subarachnoid and ventricular cysts, they cannot be destroyed by your praziquantel, and that is the reason why we give albendazole. Right, that is the reason why we give albendazole. And if you want to give praziquantel, what is the dosage of your praziquantel? That is around 15 milligrams per kg per day. You have to give for nearly 15 days. That is about the dosage of your praziquantel. Now, see, whenever you are giving an albendazole, like what is the type of food the individual has to take? Right, what is the type of food the individual has to take? I'll explain you this. Now, whenever you are giving albendazole, remember it should always be taken with a fatty meal. This is a very, very important advice that you need to give to the parent. Okay, why? Because the purpose is that fatty meal will improve the absorption of your albendazole. And that is the purpose why you need to give albendazole along with the fatty meal. Right? Very good, Avinash, and as well as Arun, you have answered this correctly. Right, so that is about the story of your what is the dosage of your albendazole in patients with the neurocysticercosis. Then we will move on to the next question. Yeah, what is the disease spread by cannibalism? Nipah virus, nocardiosis, Kuru, Madras motor neuron disease. Very easy question and very important question as well. Nipah virus. No. Yes. Devarkonda Abhinav Babu has answered. Yes. Bindu, you have also answered this correctly. So the answer is Kuru. Right. So the word cannibalism, that is your K, even though the alphabet is C. And Kuru is also your K. So remember that the disease which is being spread by your cannibalism is your Kuru. Okay. So that's a very, very important question. Right. Yeah, the another name of this particular Kuru is your mad cow disease. Yes, this is another important question. Which of the following is the most common cause of meningoencephalitis in children? Mumps, arbovirus, herpes simplex virus, enterovirus. Which of the following is the most common cause of meningoencephalitis in children? Right, very good, excellent. So everyone is answering this correctly. So the answer is the enterovirus. The most common cause of meningoencephalitis in children is your enterovirus. So this is a very important question that you need to remember. Now, you take the next question. Post-herpetic neuralgia is seen after 1 week, 2 weeks, 3 weeks, 4 weeks. Right, excellent. So when do we use the word post-herpetic neuralgia is that when the vesicles, when they are formed along the dermatomal distribution after 4 weeks. That is the point when we use the word post-herpetic neuralgia. So post-herpetic neuralgia is seen after 4 weeks. So can anyone tell me what is the treatment of this post-herpetic neuralgia? What is the treatment of post-herpetic neuralgia? Any one of you? Treatment, please. Right? So it is basically a neuropathic pain. Right? It is basically a neuropathic pain. Now this neuropathic pain has to be reduced. So what are the drugs that you can give? You can give pregabalin, you can give gabapentin, you can give carbamazepine, right? So carbazepine. So these are the drugs that you can give for the treatment of post-herpetic neuralgia. But apart from these drugs, there is also a solution which is available, and the name of that particular solution is, one second, yeah, this is the name of the solution, that is Burroughs solution. Now what does this Burroughs solution contain? It is aluminium subacetate, right? It is an aluminium subacetate. So you have to apply this particular Burroughs solution 4 to 5 times per day over the broken vesicles, and then you need to remove the serum and as well as the crust. Now what is the advantage of this solution is that this will reduce that neuralgic pain, right? This will reduce the neuralgic pain. So that is a very important point. The name of the solution is Burroughs solution. What is the content in that? Aluminium subacetate. And apart from that, you also need to give the antiviral drugs, that is valcyclovir or famciclovir, for 7 to 10 days. But symptomatic management is very important in this patient because the individual is very much worried about that particular burning type of pain. So that is about your post-herpetic neuralgia, which is seen after 4 weeks. Next, we will move on to the next question. Yeah, what is the diagnosis of this particular patient? Myasthenia gravis, congenital myopathy, inclusion body myositis, muscular dystrophy. Right. So yeah, Bindu, Adita, Blessy, Abhinav Babu, Raju, you have answered this correctly. That is your muscular dystrophy. Can you people tell me why did you answer it as muscular dystrophy? Why are you telling this as the muscular dystrophy? Right? Now, inverted champagne bottle appearance you will have in case of CMT, Charcot-Marie tooth disease. Adita, you said inverted, yes. So Blessy has come with up an answer there. So what is that you are noticing here is the pseudo hypertrophy in the calf muscles. Right? You are noticing the presence of pseudo hypertrophy of the calf muscles. Now, where do you have this particular pseudo hypertrophy of the calf muscles? That is seen in patients with congenital muscular dystrophy. Okay, congenital muscular dystrophies. Okay, can anyone answer me what is the most common type of congenital muscular dystrophy? Any one of you? What is the most common type of congenital muscular dystrophy? Very good, excellent. Adita, Blessy, you have answered this correctly. So the most common type of congenital muscular dystrophy is the Duchenne's muscular dystrophy. Right, not Becker's, not Nemaline myopathy. It is your DMD. Duchenne's muscular dystrophy is the most common type of the congenital muscular dystrophy. Right, so very important question. Yes, we will move on to the next question. I have a 65-year-old patient, right, and he was diagnosed with ST elevation MI, and he was thrombolized with streptokinase. And after that, the ECG tracing is performed after thrombolysis. Tell me, what does it exhibits? Ventricular bigeminy, accelerated idioventricular rhythm, ventricular tachycardia, Wenckebach's phenomenon. Right. Excellent, Santanam and as well as Bindu. The answer is accelerated idioventricular rhythm. Now you see, Avinash, you are answering it as ventricular tachycardia. See, you take your option as, achha, you by mistake you have typed. Okay, fine. So in VT, what should be the heart rate? The heart rate should be at least more than 200 to call it as VT. But if you see the heart rate there, it is not 200. Now, how to recognize the accelerated idioventricular rhythm? Let me explain you. First of all, accelerated idioventricular rhythm is the one which will occur post thrombolysis. STK stands for streptokinase, which is nothing but your thrombolysis. Now, very important point is that they will have wide complex. You see this? This is a wide QRS complex. Right? And another important point is, you notice there is no P wave. Right? There is no P wave. Now, what do you mean by this word idioventricular rhythm? The word idioventricular rhythm is that it is the rhythm which is originating from the ventricle. Right? It is originating from the ventricle. Now, why it will originate from the ventricle after your thrombolysis? Let me explain you. Now, you see, for example, this is your ventricular myocardium. Right? And this part of the ventricular myocardium has been dead. Why? Because of the blockade of the vessel. Now what you have done, you have given STK and you have dissolved this particular thrombus. When you dissolve this thrombus, the perfusion to this myocardium increases. Whenever the perfusion to the myocardium increases, that part of the myocardium will try to generate an impulse, and that is what is called as idioventricular rhythm. And why you will have the wide complexes? There is an explanation for this, why you have wide complexes. The explanation is that the velocity of the conduction of the impulse which is originated in the ventricle will be very slow compared to that of the impulse which has originated in the SA node. That is the reason why the complex you will have is a wide complex in case of AIVR. The concept is very simple because of slow conduction of impulse which is originated in the ventricle. So the answer is AIVR, accelerated idioventricular rhythm. Right. Yes, if there is presence of AIVR, it tells that there is a good response to your thrombolysis. Right? There is a good response to your thrombolysis. No, in AIVR, the rate need not be more than 100. It is not a compulsion. Yes, Adita, the rate need not be more than 100 in AIVR. Now, we will move on to the next question. Yes. What does the following ECG shows? Osborn wave, delta wave, hockey stick sign, epsilon wave. Very good, excellent, Avinash. So this is your hockey stick sign. I'll show you this. This is your hockey stick. Okay, so I can draw this in each and every complex. Okay, so now what is this suggestive of? Right, Avinash has already said. Very good, Avinash. So this is suggestive of your digitalis toxicity. Right, this is suggestive of digitalis toxicity. So in digoxin toxicity, you will have what is called this hockey stick sign, right, or we call it as inverted mustache sign. Right, inverted mustache sign. Okay, now we will see the other options. Now what about this Osborn wave? Can anyone tell me where do you have this Osborn wave? Right, very good. Yes, Osborn wave is the one which is seen in patients with the hypothermia. And what is this Osborn wave? It is a positive deflection at the J point. And you will have this Osborn wave in patients with hypothermia. Alright. So this is your Osborn wave. Now, Followed by that, the other option like what we have is the delta wave. Now if you take this delta wave is the one which is seen in patients with the WPW syndrome, that is Wolff-Parkinson-White syndrome, right? What is this? It's a pre-excitation syndrome. Now this is your WPW syndrome. What are the features of your WPW syndrome? The features of your WPW syndrome is that you will have a short PR interval, right? And there is presence of your delta wave. Right, there is presence of your delta wave. Okay, so that is what is the ECG suggestive of your WPW syndrome. Then you have another wave like that is your epsilon wave. Can anyone tell me where do you have, in which condition you will have this epsilon wave? In which condition you will have this epsilon wave? Right, very good Avinash, excellent. So it is seen in patients with ARVD, that is arrhythmogenic right ventricular dysplasia. And where will you see this epsilon wave? Mainly in lead V1. In lead V1 you will see this epsilon wave. I will show you that. Right, so this is your epsilon wave seen in lead V1 in the ECG, seen in patients with arrhythmogenic right ventricular dysplasia. Okay, now yes Avinash, what is the treatment of choice for ARVD? What is the treatment of choice for ARVD? Yes Santanam, what is the treatment of choice for ARVD? Right, so what is the cause of death in these patients with the ARVD is that ARVD patients, they can have sudden cardiac arrhythmias. Right, they can have arrhythmias and they can have a sudden cardiac death. Right, very good Santanam, excellent, you have answered it correctly. So you should put implantable cardioverter defibrillator. Now what this defibrillator will do? Defibrillator will inhibit this particular arrhythmias and thereby it will prevent this sudden cardiac death. So that is the purpose why you need to implant the patient with the ICD. So the treatment of choice in patients with ARVD is intracardiac defibrillator. Right, so that completes the discussion of last minute revision points part 4. Right, so for those students who did not watch last minute revision points, like I have conducted 4 sessions completely. Part 1, part 2, part 3 is there. Please watch that. That will be very much useful to you, mainly for the Fmge students, right? But your exam is postponed, but these particular points which I have covered in all these parts are very much useful to you. And I wanted to bring to you a very important notification that now Unacademy, it is coming up with a very unique program. It is free course. What is that? I'll tell you. Unacademy is conducting 4 free tests for AIMS exam. And what will be the level of paper? The level of paper will be difficulty. Right, and these tests are going to be absolutely free. And when are they conducting this? They are conducting this in the month of May, every Sunday at 10 a.m. Right, at 10 a.m. Unacademy is going to conduct 4 free tests for the AIMS exam. That is going to be a free test. And the beauty of this is, the beauty of this particular exams is that after the exam you will be having the discussion of that particular paper also. Right, so different mentors, right, we have many mentors on this Unacademy platform. So each mentor will discuss their subject related questions. That will be also completely free. It is not subject wise, it is like all the syllabus, the entire syllabus, like you will be having the AIMS exam. But what I wish is you people should get exposed to these particular questions. At least you will understand how the question paper pattern will be. But even though you are unable to answer, don't worry. We are there for you to help you how to solve those particular questions. So we will be also having post-analysis session on those particular question papers which have been conducted to you. So please tell your friends, yes, like real aims. You will get the feel of that you are writing the aims exam, right? So please inform your friends also that this exam is going to be completely free. That will be conducted on Sundays 10 a.m. for 3 hours, right? So with this particular notification, I'll just wind up this particular session. So good night everyone, stay healthy, stay happy, read well and do well. Thank you very much.